Good morning, everyone. Thank you all for being here. This will actually be our last hearing as OHS, so let's make it a good one. Um, Johnson Memorial Hospital, which is part of Trinity Health of New England Corporation, has filed an application for a certificate of need, seeking approval from the Office of Health Strategy to terminate its outpatient cardiac and pulmonary rehabilitation services. The hospital stopped providing the services in September 2025 and subsequently submitted this application. The anticipated capital expenditure associated with this project is $0. Today is June 11th, 2026. My name is Dan Chuka. The acting OHS Commissioner, Amy Porter, has authorized our legal director, Tony Casagrande, to designate hearing officers for CON matters, and he has designated me to serve as the hearing officer for this matter. Specifically, he has designated me to rule on all motions and objections and recommend findings of fact and conclusions of law upon completion of the hearing. This hearing is being held online only, utilizing the Teams video conference platform as authorized by Connecticut General Statute, Section 1-225A. In accordance with that statute, any person who participates orally in an electronic meeting should make a good faith effort to state his or her name and title at the outset of each occasion that that person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and silence any additional devices that are around them. This public hearing is being held pursuant to Connecticut General Statute, Section 19A-639A, sub F, sub 2. It's otherwise known as an F2 hearing. Although this does not constitute a contested case under the Uniform Administrative Procedure Act, the manner in which OHS conducts these proceedings will be guided by the UAPA provisions and the regulations of Connecticut state agencies beginning at section 19A-9-24. I will be asking the majority of the questions, but OHS staff are also present to assist me in gathering facts related to this application, and they may also be asking questions of the witnesses. At this time, I'm going to ask each staff person with me to identify themselves with their name and their OHS title, starting with Steve Lazarus.
Good morning, Stephen Lazarus. I'm the CON Program Supervisor. Annie?
Good morning. My name is Annie Fiella, and I am the CON Team Lead.
And Andrea Harrison will also be joining us. She's having some technical difficulties, but she will be back. Her last name is Harrison. And what is her exact title? Do either of you know?
She is healthcare analyst.
Okay. Thank you. Also present is Faye Fentis. She's our paralegal who is assisting with the hearing logistics, gathering of the names for public comment, and providing miscellaneous other support. Speaking of public comment, sign up for public comment has started. If you would like to make a statement at today's hearing, please put your name in the Teams chat and we will be happy to provide you with an opportunity to do so later on. Sign up will continue until the technical component of today's hearing has ended, which I expect will be probably by 12 o'clock. You can also submit written comments to concomment@ct.gov for up to 7 days from today. I was just told that the Teams chat is disabled, so you would actually use the Q&A function to provide your name, not the Teams chat, so I apologize. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, members of the public, and our staff. Our priority is the integrity and the transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being recorded, and the video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available for review through our CON portal, which is accessible on the OHS webpage. In making my proposed decision, I will consider and make written proposed findings regarding Section 19A-639 of the Connecticut General Statutes. And lastly, I do wish to point out that by appearing on camera in this virtual hearing, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time by exiting the meeting. All right, I am going to start by going over the exhibits and the items of which I am taking administrative notice, and then I will ask if there are any objections. The CON portal contains the pre-hearing table of the record in this case. Exhibits are identified in the table from A to U. I did notice one issue with Exhibit U. Specifically, it states that the agenda and the table of record were uploaded on 6/9. It was actually uploaded 6/10. We had intended to upload it on 6/9. We just didn't finish them in time. So we will correct that when we upload the final table of record. Counsel for the applicant, Attorney Anthony, can you please identify yourself?
Yes, good morning, everyone. I'm Bob Anthony. I'm the General Counsel for Trinity Health in New England, and I'm appearing on behalf of Johnson Memorial Hospital, which is part of Trinity Health in New England.
Thank you, Attorney Anthony. Other than the issue that I noted with the upload dates, did you have any objections to any of the exhibits that were identified in that list?
No objections.
Thank you. So all identified and marked exhibits are entered as full exhibits. JMH is also hereby noticed that I am taking administrative notice of the following documents and dockets. The statewide healthcare facilities and services plan, as well as its supplements. The facilities and services inventory. And docket number 25-32843-ECON. That's the emergency CON application docket through which Hartford Healthcare was approved to acquire Prospect, Manchester Memorial Hospital, and the Rockville General Hospital campus. You're probably asking yourself what the relevance of that docket is, but I will tie it all together. And it'll make sense. I just have one question about how that docket may align with this one. Attorney Anthony, do you have any objection to me taking administrative notice of those documents or that docket?
No, no objection.
Thank you. As is sometimes the case, I may also take administrative notice of other things such as prior OHS decisions, agreed settlements, and determinations that may be relevant, but which have not yet been identified. Although unlikely, this may also include excerpts from the OHS Acute Care Hospital Discharge Database, the All Payer Claims Database, and the Hospital Reporting System financial and utilization data. If applicable, I will provide the applicant with an opportunity to respond to anything so noticed, either here or in writing after the hearing. Attorney Anthony, do you have any additional exhibits that you wish to enter into the record at this time?
No, we do not.
Okay. Then we will proceed in the order established in the agenda for today's hearing. I would like to advise the applicant that we may ask questions related to your application that you feel have already been addressed through your submissions. We will do this for the purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. I want to reassure you that we have reviewed the docket, and I will do so again a number of times before issuing a proposed decision. Anyone attending today should enable the use of video cameras when testifying or commenting remotely during the proceedings. However, all participants and the public should mute their devices and should disable their cameras when we go off the record or take a break. Please be advised that although we will turn off the recording, audio and visual may continue to be accessible. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, I may allow public officials, if there are any, to testify out of order. I or OHS staff will call each individual by name when it is his or her turn to speak. And again, registration for public comment has already begun and will start immediately following the technical portion of today's hearing. The applicant's witnesses should be available after public comment in the event anything comes up in public comment that OHS feels they need to ask additional questions about. With that, Attorney Anthony, I understand at least one of your witnesses plans to make an opening statement. I didn't know if you had any preliminary remarks you wanted to make as well, but you should feel free to start with however you would prefer. And if you can actually just please identify the individuals by name and title who are planning to provide remarks, that would be helpful, and then I could swear them in and just take care of that issue.
Okay, well, again, thank you very much. And just for the record, I don't know, hearing officer, if this is necessary, but I want to note that the applicant does adopt the CO1 application and all supplemental submissions into the record. And the application, as you noted, proposes the discontinuation of cardiac rehab and pulmonary services at Johnson. And Dr. Robert Roos, the president of Johnson, will speak and describe, how the program has experienced sustained low utilization and it's duplicative of services available elsewhere within the region, and that patients will continue to access through other providers in the region, and the hospital has established a transition protocols to ensure continuity of care. So with that, I'm going to turn it over to Dr. Roos, if that's okay, to give his opening statement and overview of the application.
Sure. Let me just swear him in before we go any further. Do you have anyone else attending today who may be providing comment in response to questions or?
Yes.
We do. Yes.
Okay. So maybe I'll just swear everybody in at once and then Dr. Roos can start.
Perfect. Yep.
Would you mind introducing those individuals?
I can certainly do that.
Okay.
In addition to myself, Dr. Robert Roos, president of Johnson Memorial, I'm joined today by Patrick McCormick, our regional executive director for the cardiovascular service line for Trinity Health of New England, Lindsay Gamble, chief nursing officer, vice president for patient care services and operations at Johnson Memorial Hospital, and Carolyn Alessi, our regional director for community health and well-being for Trinity Health of New England, who may all provide answers to questions that could come up in this hearing.
Okay, thank you. I'm going to ask you, Dr. Roos, and each of those individuals who were just identified to raise their right hand and make sure your right hand is visible in the video. Please, do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give in this case shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
Yes, I do.
Yes.
I do.
Okay, let the record
second.
reflect that everybody answered in the affirmative. So Dr. Roos, you can start with your statement.
Thank you and good morning. My name is
morning.
Dr. Robert Roos, and I serve as the president of Johnson Memorial Hospital, which is part of Trinity Health of New England. And in this role, I am responsible for the overall performance of our organization, including the quality, safety, and accessibility of the care that we provide to our community. I am joined by other leaders representing Johnson Memorial Hospital and Trinity Health of New England. Thank you for the opportunity to provide some testimony regarding the proposed termination of our outpatient cardiac and pulmonary rehabilitation services at Johnson Memorial Hospital's Enfield location. The decision did not come lightly. Cardiac and pulmonary rehabilitation services are an important component of the continuum of care for patients recovering from cardiovascular and pulmonary conditions. However, over the past year and more, we have experienced significant operational challenges that have made it increasingly difficult to sustain this program at the Enfield site. Most notably, the program faced substantial workforce constraints, including the loss of key nursing staff through resignation, retirement, and medical leave, changes which ultimately resulted in the inability to consistently meet the required clinical staffing standards for operating the program. Secondly, and at the same time, we observed a significant and sustained decline in patient volume over a multi-year period, further challenging the long-term viability of the program in this location. So faced with those realities, we made the difficult decision to cease operations at the Enfield location in September of 2025 to ensure that we could meet the standards for patient care. And that's why we're here today. Important to note, this action does not represent a withdrawal from our commitment to provide these services, cardiac and pulmonary rehabilitation services. Rather, it's a transition in how and where we provide them so that patients continue to have access to these services within our system, Trinity Health in New England, and through established community providers. We have taken steps to ensure continuity of care for all the patients, including proactive communication with patients and providers, coordinating referrals, and supporting through other community health resources when needed. The decision reflected a balance of patient access, workforce realities, and the need to ensure sustainable high-quality care. And the principles driving this are to maintain efficiency in delivering services, fiscal stewardship, and maintaining access without interruption. And so while difficult, this decision allows us to focus our resources where we can continue to provide them in the most reliable and comprehensive way, while not interrupting and continuing to maintain access for our patients. Thank you.
Thank you, Dr. Roos. Attorney Anthony, did you have any other witnesses who wanted to make statements?
No, we don't.
Okay. And did you have any questions, so any direct questioning for Dr. Roos?
No, I do not.
Okay. We are going to jump into OHS questions then. And for the most part, they're going to track with your responses to the issues that were attached to the order for pre-file testimony and hearing issue responses. So you probably would want to take out that document if you have a copy of it, either electronically or in paper copy. And the first question I have for issue 1A is, how is this table developed? And what do the numbers represent? Are those patient visits? Are those?
Yeah, good morning. This is, oh, sorry. I can comment on it.
That's fine.
Patrick McCormick, Regional Executive Director for Cardiology, Cardiovascular Services. That is a table of unique patients. So it's a count of one patient. They may have multiple visits, but it's a unique patient count for those years.
Okay. That's helpful. So Johnson stopped providing services in September of 2025, correct?
Correct.
So their fiscal year follows most other fiscal years of hospitals. So it's fiscal year 2026 runs 10/1/2025 through September 30th, 2026. So the question I had is, how are there any numbers for Johnson Memorial for fiscal year 2026 if you stop providing those services before
Our
then?
fiscal year is actually July 1. So the numbers that you're seeing for 2026 would be July, August, and a portion of September.
Interesting. I didn't realize that.
Yeah.
Yep.
And just for clarification, we do file with OHS on the October 1, September 30th, the data that's required. But Trinity operates on a July 1 through June 30th fiscal year. So we prepare both sets of finances.
Okay.
Mm.
That's helpful. Thank you. And one other question about that table. Does that provide full fiscal year data? Or is it annualized for fiscal year 2026 or, you know? So specifically for 2026, does that represent the full year annualized, or is it up until the point at which this was filed?
Johnson is up until the point this was filed.
Okay.
Yeah.
And just for clarification, would the same apply to St. Francis and St. Mary's? That data is current as of when this document was filed?
Yes,
Okay.
correct.
So we can look at issue 2 now, which starts on the second page. We wanted to talk more about what planning Johnson has undertaken to ensure continued access.
Mhm.
So JMH stated that it began communicating with providers in August of 2025 to notify them of the termination. Communicating with patients and providers. I think I may have just said providers. The letters that were provided with this issue response, they were dated September 10th. I was just wondering if there are any earlier communications that you would be able to direct us to.
There is no prior communications in print. In the summer, when we lost the 2 full-time nurses, we started communicating with referring physicians and patients because our schedule was already impacted at that point. But in print, once you come up with a formal plan to shift those patients to the Hartford market to continue providing access, we sent the letters to the patients and the referring providers at that point. So those would be the September dated letters.
Okay. So you said you had formally developed a plan by September 10th, and that's when those letters were sent out. What planning occurred prior to that point? I mean, you obviously were losing staff in October 2024 through May 2025, or June actually 2025.
Yeah, so go back to October 24, it was a retirement of the front desk and scheduling colleague. The colleague that was remaining there, she was part-time but willing to work full-time hours while we were recruiting. We did make a couple offers that would declined, but we had enough support to sustain the front desk operations and scheduling. There was no issues there. We also had backup at other locations that could support remotely if needed. In May of 2025 is when we lost the full-time cardiac nurse and supervising nurse. So we initiated recruiting at that point. We lost the second nurse in June. And that's really when things started to get tight. So we had to downsize our schedule. We communicated with 2 of our per diem RNs that were of the legal retirement age, but they were very vested in the program. They had been in the program for many years. So they offered to provide support to continue patient care and keep our schedules open for as many hours as we could. One of the per diem nurses was unfortunately very badly injured in and around August, I'm going to say early August. And the second per diem nurse was unable to provide additional hours because she was at her max level of hours for her retirement funds. So she couldn't contribute really more than like 15 hours a week. So it was probably right around early August that we knew we needed a more formal plan, that recruiting and continued efforts to try to keep the location viable just wasn't going to work. So at that point, that's when we formalized a plan with our Hartford facility to ensure that we had the appropriate access. But also the Hartford facility has the ability to scale operations to absorb those patients. We have the physical space as well as the support staff to do that. So that's when we kind of came up with a more formal plan in September.
Okay. And just for the record, when you say the Hartford facility, you're referring to St. Francis or one of its outpatient locations?
Yeah, it's actually St. Francis proper. It's actually in the
Okay.
hospital. Yeah. Yeah.
All right. It was noted in the application that the board met in July of 2025 and approved the termination. So how does that sort of fit in with what you were just talking about in terms of developing the plan in August and September?
Yeah, I think we were challenged to recruit. There's not a lot of cardiac rehab nurses there that are in the market. And some of those cardiac nurses are not as comfortable working outside in an off-campus facility. Our two facilities at St. Mary's Hospital and St. Francis Hospital are embedded right in the hospital program. So there's redundancy there. So we were challenged with recruiting. So I think at that point, we notified the board that we're, at risk. So I think we're just trying to risk rate, how successful we're going to be in recruiting versus having to look at a more permanent solution of, moving the patients to St. Francis.
Okay.
Mhm.
And Dr. Roos
Mhm.
or anyone else who's joining it, if any of you have any additional comments, feel free to jump in and stop
Sure.
me. And
Yeah, I don't have much to add to what Patrick said. I will reiterate that we had conversations with the board to ensure that they were aware of the challenges and endorsing the plan that we needed to embark upon to address those.
Thank you.
Yep.
So Johnson noted in its response to the completeness letter that staffing of cardiac and pulmonary rehab services is a problem at all of its locations. Are any of Trinity Health's other programs at risk of closing, either St. Francis or St. Mary's or anything else in the Northeast?
No, I would say no. The two remaining departments at St. Mary's and St. Francis have redundancy and backup because they are on campus. I think the biggest difference for us is with the Enfield location being off campus. It was not nearly as nimble as the hospital-based program. So we do have exercise physiologists maintaining both programs with nurse redundancy, backing them up, as well as physician support. So that was really the biggest difference is the off-campus versus on-campus and lack of redundancy to really sustain the loss of staffing that we did in Enfield.
Okay. So here's where that docket that I took administrative notice of comes up. So again, that's docket 25-32843-ECOM. One of the other entities that Johnson identified as having the ability and capacity to absorb these rehab patients is the Rockville campus of Hartford Healthcare's Manchester Memorial Hospital. Have there been any communications with Hartford Healthcare, Manchester Memorial, or their Rockville campus to confirm that they plan to continue providing cardiac and pulmonary rehab services?
I I have not had any formal conversations with their leadership. I know at the office level they have. It's a small group of cardiac exercise physiologists that have all kind of worked together over the years. So they commonly will move patients back and forth based on patient preference. So it's really just, this is a service that's really the continuum of care for patients that have come out of our cardiac and pulmonary program. But to answer your question directly, I had not had any communication directly with their leadership for that.
Okay. And Dr. Roos or anyone else, have you?
I don't,
Or-
I have not. I don't believe there was.
Okay. Um, does Trinity Health provide any at-home cardiac and pulmonary rehab services?
We do not. We have discussed it. We've met with a couple of outside organizations that do provide care that work directly with the patients, but we've not formalized any outpatient home-based services to date.
Would that be an option for the patients in Johnson's PSA?
There,
By PSA, I mean primary service area.
Yeah.
Would that be an option?
can I just speak to that? And Patrick,
Sure.
please add some
Yeah.
additional thoughts. Providing home-based services is not part of the array of services that Trinity Health of New England currently provides. However, to Patrick's point, we had contact with at least one provider of home-based cardiac pulmonary rehab services that do provide services in the primary service area of Johnson. So there are organizations that do exist in the area that do provide services that patients can access. Yes. We don't provide them, but they do exist.
Okay.
And
If you're able to speak to it, how do
Yeah.
those compare in terms of intensity and quality?
Yeah, there are different levels of cardiopulmonary rehab. I'll let Patrick talk to the level of those rehab services that can be provided at home. The conversations that I and other clinical leaders were a part of suggested that they do offer a high quality, convenient service for patients. But I'll let Patrick kind of round that out.
Yeah, I was actually quite impressed, honestly, with their home-based services. We met with the organization. I could get you the name, but they're a Connecticut-based organization that provides at-home live interactive training. So they drop off either a treadmill or a bike with Wi-Fi cell service, and then there's actually interactive live trainers that monitor the performance of the patient as they're doing their exercise workout. Their vitals and telemetry are monitored. So it's actually a pretty impressive setup. It does account for a large percentage of our patients because we had cardiac phase 2, which essentially would be covered under those services. So it is a very viable option for this market.
And does that provider, do they provide any other services, or is it limited to at-home cardiac and pulmonary rehab services?
They did have other services. I think in the orthopedic realm, we were mainly looking at the cardiac services for reasons of this. But they did have a few other areas that they had focus in, yes.
And does that involve any in-person, like do they send someone to the home, or is it all done remotely?
From a provider standpoint, was all remotely. They send technical support to basically ensure that the equipment is appropriately set up and connected. And then all of the provider support is remote.
Okay. It sounds like Johnson doesn't currently have a contract with them for,
We do not.
okay, for either that or orthopedics?
No,
We,
not currently.
we do not have a contract. We are able to make those services available to people to do their, to do intakes, but don't have a contract with them.
Okay. Is it also fair to say you haven't referred any patients to that provide or that
Mm.
third party in terms of like a referral yet?
Not that I'm aware of.
Okay.
No, I believe our referrals have gone to other physical locations that are providing cardiopulmonary rehab services, including at St. Francis.
Do you happen to know how those services compare so that the at-home services that third party provides, how those compare in terms of costs and insurance reimbursement, that sort of thing?
Not
Not
fully.
directly.
I think we had a very high level. I think, but we didn't get into the details as far as the patient level, as far as billing.
Okay. And when about did you have that conversation, if you can recall?
Ooh. I'm gonna say it was in the fall of calendar year 25, so somewhere in the September, October, somewhere in that time frame.
Okay. So is it fair to say then that this was tossed around as an idea in terms of ensuring continued access to cardiac and rehab or cardiac and
Mhm.
pulmonary
Mhm.
rehab?
Yeah, it is, I mean, remains still an option for a referring physician to reach out to that group to set it up for the patient or the patient to set it up, but it was something that we looked at from a contractual standpoint for Trinity Health in New England.
Okay. Shifting focus a little bit, but still sticking with issue number 2. After you sent out those letters in September to the providers and the patients, did you receive any feedback from the providers or the patients, either positive, negative, or neutral?
Very little. Our internal providers, we have PSA agreements with cardiologists in the Enfield area that had been referring patients to that location. So they had reached out just saying, it had been a long-standing program, but they understood the constraints. They were aware of the challenges we faced. So they had no issue referring to St. Francis because they also have their primary office is across the street from St. Francis Hospital. I think I made note of one patient that did reach out. We did have patients that were, we call, say, phase 3 of cardiac rehab, which is they used it sort of as a gym, if you will, to go in and work out and socialize. So there's one, maybe two. I think Dr. Bruce may have received one, but very, very few.
Okay.
That's correct. I can recall receiving an email from 1 or 2 patients that had been long-term using the facility there, as Patrick had described.
Okay.
But recognizing that, there were challenges and they had opportunities to continue that care elsewhere, but expressed their thoughts on the changes. That was it.
Okay. Just for my information, I know this was described somewhere in the documentation, but you just mentioned, I can't recall which one of you mentioned this, but phase 3. So what are the different phases of rehab?
Yeah, in simplest terms is there's really phase 1's inpatient, phase 2 outpatient, and then the phase 3 was kind of maintenance, maybe for lack of better description, where the patients could come in and pay a fee of like $5 or $10 and come in to use the facility, the equipment. They weren't necessarily interacting directly with the nurse, because the nurse would be doing classes, but they could come in and use the equipment. It's a relatively small square foot gym, but if you envision what your standard gym looks like, it's just a small format of that.
Okay. Um, So if you look at the table, it's at the top of page 2 of the issue responses. I think I know the answer to this question, but I just want it confirmed. It appears as though patients are not being referred to St. Mary's based on that table, because there's zeros all the way down and then 0 percentages. Is that correct? Or is that information just missing?
Uh,
I believe
I-
that would represent, if I'm not mistaken, that would represent that there are not patients from Johnson's primary service area receiving care in Waterbury.
Okay.
Right, yeah. Sorry, I'm just reading over that. Yeah.
We do have the ability to refer them. But knowing that Hartford is closer, those patients generally would prefer and end up receiving services at St. Francis.
That was my assumption, but I just
Yeah.
wanted to confirm
Yes.
for the record.
Yes.
Yes, yeah.
Um, so looking at issue number 3 now, that starts at the bottom of page 2 and continues on to page 3 of the issue responses. And when I say issue responses, I'm referring to Exhibit O in the record. You indicate the driving restrictions are extremely common and expected for patients recovering from cardiac procedures. The restrictions seem to be pretty significant. So what is your understanding as to how most of Johnson's patients were accessing the rehab services at the time that Johnson was still offering them?
Yeah, I don't know that I could actually objectively answer that question. I don't think we really took record of how the patients arrived to the facility, the restrictions we placed by the referring provider. So I think they did have, I think there was a few different options. Trinity Health in New England provides a few transportation options. But I don't know that I could really objectively answer how the patients arrived to that facility or departed the facility.
But it's safe to say that most of them weren't driving themselves, given the restrictions, correct?
Yeah, I mean, the complexity of cardiac open heart surgery or valve replacement type of thing would be a recommendation not to drive to rehab. Yes.
Okay. You mentioned that it has a few transportation programs. I'm aware of the Lyft transportation program. Are there other ones?
Yeah, I believe Carolyn Alessi is on.
Yes, thank you, Patrick.
Thank you.
This is Carolyn Alessi. I'm the Regional Director for Community Health and Wellbeing for Trinity Health in New England. In addition to the medical ride programs such as VAO, we do offer our Lyft ride program to those patients that are eligible, who have been screened for social influences of health and have screened positive for transportation. And it is no cost to them to take this resource.
I'm a little familiar with VAO. Is that limited to Medicaid recipients only, or is that open to other populations?
I believe it's Medicaid and, if I'm not mistaken, Medicare,
Okay.
but it's not available to everyone.
While you're talking about this, I guess I'll skip forward a little bit to some of our other questions. Let me just mark where we left off. So in response to issue 6C, there was a little bit of an issue with the numbering of your document. So after issue number 5, you reverted to issue number 4A. So that starts at the bottom of page 5, but 4A there is actually 6. So I'm referring to that one. It's at the bottom of page 5. It says issue number 4A, and it starts specifics regarding revenues or losses. Actually, no, I'm not. I'm looking at 6C. I apologize.
6C.
So that's actually on page 6. So there you talk about the Lyft Ride program. And you say that it's for eligible patients only. So those who have been screened for health-related social needs where transportation is a barrier. Can you talk more about that? Like, what are the health-related social needs that qualify? What are the barriers, and how does that work?
So as part of our standard practice, we do screen our patients for social drivers of health, so food insecurity, housing, transportation, utility, financial risk, and among other categories. And so once a patient is screened, whether it be through an ambulatory screening through MyChart Push or through an inpatient screening, we do have within their patient chart, within our electronic medical record, the results of those screens. And those screens, if they're screened positive for transportation, then our case management team or provider makes referral to our community health worker social care hub, where we will start to make arrangements for transportation post-discharge, and then also to continue their care in the community.
Okay. What percentage of Johnson's patients in the service area require or utilize that ride program?
Currently, we have a low utilization rate within Johnson Memorial's service area for the LIFT program.
Is that due to people not qualifying or people not being interested?
It's a combination of not being qualified and already having transportation or family in place to take them to their appointments.
Okay. So if you were looking at it in terms of 3 different groups, VEO, Lyft, and providing their own transportation, what would the disbursement be between the 3, if you're able to speak to that?
I don't have that data specifically, Daniel, but from our Lyft the Ride program, we don't see a high utilization within this service area. Now that can change as patients start to seek services in St. Francis footprint, and will need transportation going from Enfield into Hartford.
Okay. Is that something that you would be able to provide after the hearing? Like, is that something that you're able to generate from either Trinity's or Johnson Memorial's records, just so that we have a better understanding of
Okay.
current utilization of the different transportation options?
Okay. I can take that back.
Okay. So I'm going to mark that as a late file. So we can talk a little bit more about what late files are later on, but they're essentially just things that we request that you provide after the hearing adjourns. And if you go back to your office or it seems you're already in your office. But if you go back to your office and you determine that you can't actually provide that either due to IT limitations or whatnot, then, you know, we won't hold it against you. But
Okay.
I do think that would be helpful just to have a better understanding of what's going on right now. So in response to issue 6C, it's also mentioned that the Lyft transportation program is grant funded. Are you able to provide any specifics about the grant?
So we have several different funders that support this program, whether it be through grant applications that we seek out or donations to the program. But we continue to provide this. This program has been in existence for 4 years now, and we've not had any issue with a lack of resources.
Did you say 4 or 40?
4
Okay.
4 years.
And when you say this program, you're referring to the Lyft
The
program?
Lyft ride, yes.
Okay. Have there been any discussions about Johnson or Trinity reimbursing patients for the difference in fuel costs, either between driving to the Enfield location and Hartford? And
I would say.
this goes to
Yeah.
all three of you. I don't know who's
I-
best equipped.
I would say no, not that I'm aware of.
Yeah. We have not.
Okay. Are there actually, well, I'll take that back. All right. We can go back to where I left off a little while ago. Going to pick up at issue number 5, which is at page 4 of Exhibit O. And I actually want to turn to the page that follows that on page 6. There are 2 tables. One is distribution of unique patient visits and distribution of visit type. Can one of you just walk us through what each of these tables represent and the information that they show?
Sure, I can do that. So that the top graph is trying to demonstrate the distribution of unique patients, unique patient count, and the visit frequency. So in this example, or this data set, there was 28 unique patients that had 36 visits, which really would equate to like a 12-week cardiac session.
Okay. And how about the second table?
Yep. Second table is just a distribution of the visit types. So these were the visit types that were offered at Johnson Memorial's Cardiac and Pulmonary Service Center. So obviously you can see the prominent visit type is cardiac rehab phase 2, which is basically the standard order for cardiac rehab services post cardiac discharge. So phase 2 would be the total number of encounters or visits, translated into visits.
Okay.
I just have a quick, sorry, Dan, I just have a quick follow-up question regarding the first chart. This is not indicative, though, of whether or not the patient has, for example, for example, the 36 visits for the 28 patients, that's not indicative saying that all 28 patients needed 36 visits, correct? Or 12 patients needed the 18 visits. Those 12, some of those patients could have needed more or less, correct?
That's correct. Yeah.
Okay.
Yeah,
Thank
and
you.
these are actuals, so these would be 28 unique patients that demonstrated the entire 36-week course.
Okay.
But yes, they can have varying weeks depending on their if they're compliant with their physician and follow through the orders and so forth. So yeah.
Thank you.
So the issue response indicates that it's 2 years worth of data.
Correct.
Which 2 years?
Yeah, so we actually went through an EMR EHR transition in November of 2024. So a lot of our patient visit data is stored in kind of long storage. So really, this would be from November 24 through September of 26.
Okay.
Mhm.
Just give me one moment here.
Sure.
I'm sorry, the top chart then is representative of the 2 years from November from 2024 to 2026.
Correct.
November 2024 through September 2026.
Correct.
Um, I'm slightly confused with these numbers then, because these numbers then in this chart are adding up to, if I added them up correctly, which I might have always missed a number, is 150. But then up above your fiscal year charts, you have very clearly more than 150.
Let me go back and take a look. Yeah, I'll have to check. I'll have to check the dates on this frequency to make sure that that lines.
So I'll just mark that as a late file that you confirm whether there is any misalignment in the numbers or how those align.
Yeah,
So
I
that
think,
way you don't have to do it right now on the record. You could take it back and look at it.
yeah, we'll do. I'll just verify what the filter date set for this. Like we're trying to take a snapshot in our new EMR to give a demonstration of the distribution of these visits.
Okay. Um, moving on to issue number 4, which is on page 3 of Exhibit O. So these questions are sort of about quality and safety. So in response to issue 4, it says you don't track patient compliance outcomes. The referring providers do. What relationship do the referring providers have to JMH or Trinity?
In that community, I mean, in that community, like other communities, there will be a mix of providers, some independent, some, where there's a professional service agreement. And I think, Patrick, not so much in that area, but not really employed up in that area from a cardiology standpoint. So mostly either through a relationship or just completely independent, referring into the center.
Yes, yeah, we do not, at Trinity Health in New England does not have a cardiology employed presence in that market. So the relationship would be, I mean, the patient is referred in, they complete their course or follow through with their visits, and then follow-up charting or visit data would be sent back to the referring physician. If it was internal, we'd go through our EHR system. External, all of the visits are documented in the Johnson Memorial Cardiac and Pulmonary Service Center.
To the extent that any of those physicians are affiliated with Trinity or Johnson, like they're part of Trinity's medical group or anything along those lines, is it possible to, export that data so that we can see sort of how many patients are fully compliant with their treatment regimens versus those who are not? I understand it would only be a snapshot because some of the providers or a lot of the providers are independent, but
Right. Yeah, I can look into that. I'm trying to think of if we capture the original order. So where the referral is, if an outside physician puts in a referral for a 12-week course, do we capture that outside of scheduling? I know that the scheduling does capture that. So they generally have a patient and they would schedule those patients for that course or that series that was ordered by the referring physician. So I'd have to see if that data was be available.
so the thing that I'm getting at is, and the thing I'm trying to figure out is, have patients started to become less compliant with their treatment protocol following the cessation of these services and at the Enfield facility? Or have they remained just as compliant despite having to travel to Hartford?
Right.
So if there's some way of exporting that data and providing that as a late file, I think that would be helpful.
We can look into that. As mentioned, without employed cardiologists in that primary service area, we may not have access to that data, and are reliant upon the feedback from providers in that community, which we have not received any feedback suggesting that they are having difficulties accessing care for their patients.
Right.
Just to that point that you asked earlier.
Okay.
But we can look and see if there are any providers who may have referred into the Enfield location previously that now are referring into the Hartford location. If we have access to that data, we can share it and submit it.
Okay. And just sort of backing up a little bit, what are some of the clinical aspects? So what can go wrong if a patient doesn't follow through with their recommended rehab services? I'm not a doctor.
I'm not. I was going to say I'm not sure I can
don't
answer.
know.
I am a doctor, but I don't want to speak for the cardiologists who might be referring those patients. So I don't know, Patrick, if you have an insight into that, feel free to offer it. If not, Certainly with any, treatment plan that's prescribed by a physician, generally speaking, compliance to that plan is important. However, if there's not compliance, then you adjust the plan. So, but you want to speak any more specifically to that? We are dealing with an outpatient service, which generally will have less risk than an inpatient service. If the patient's at an appropriate, clinical status to be able to participate in that.
Right. Yeah, I don't know that I have much more I could really comment on that. I mean, compliance to the physician order is critical, but I'm not sure I could really comment beyond that clinically.
That's fine.
Yeah. Thank you.
And that actually ties in with my next series of questions, which start at the bottom of page 5. So again, that there's a little misnumbering issue. It says 4A, but that's actually 6A.
Okay.
So you talk about it states that the patient experience is based upon a patient's ability and commitment to attend, and there is some flexibility to build the program based on what the patient needs. Can you speak a little bit more to that in any degree of specificity?
Yeah, I think ultimately we're trying to accommodate the patient themselves as far as making sure that that they are compliant and offering them the access, the availability, the time slots, the days that are appropriate for them to attend. So I think the point of that was, as Trinity Health in New England, we're not, as focused as ensuring that they're coming to Trinity Health in New England for their rehab services, but that they are going to a rehab service to make sure that they are compliant. So really, we're just trying to work with our preferred partners as well as our program in St. Francis Hospital to ensure, the patient is provided access to care. So I think that was ultimately what we're trying to communicate.
We've gone over this a little bit, but have you received any feedback that the prescribed protocol for rehab services is too onerous or something along those lines, such that the patients are unwilling to attend or complete their prescribed protocol?
Yeah, I have seen it in very general terms. Patients, a lot of these patients are still working professionals and find the 3 days per week or 12-week course is very onerous on their family and professional life. So I think those are some of the challenges we do face as far as compliance to the patients seeing the complete course through. I can't say that I have anything documented per se from a data perspective, but just some general communications I've had with patients.
Okay. And was that from prior to September of 2025 or after September of 2025?
No, I think this is just in general terms over the span. So really unrelated, I think, to the closure of Johnson, just more so in feedback of the physician's referral and course that they've recommended. So.
Okay. If you look at the top of page 6 of Exhibit O, there's a reference here to, it says for Rockville General Hospital, is closer to 312 of our cardiac rehab patients, and Bay State Hospital closer to 183 of our cardiac rehab patients. Do you see that? It's a few
Yes.
paragraphs down.
Yes.
Um, can you clarify whether you mean those hospitals are closer now that Johnson has closed its rehab services, or is it regardless of whether Johnson was providing the rehab services?
This was evaluating our patient mix by zip code to try to understand the percentage of the population that may be geographically closer to Bay State as well as Rockville. So trying to determine and project future volumes that we may have to work with to get those patients to a little bit closer location.
Patrick, to clarify that, closer to Bay State or Rockville than to St. Francis or then to Enfield?
To St. Francis.
Okay, that's what
So,
that's what I
Yeah, we are
thought.
trying to draw a distinction geographically and work with the patients. These particular patients, just to be clear, the 312 and the 183 had already completed their course of rehab. We were simply using that as a projection for future forecast for patient volumes.
Okay. And it's possible that some of those patients were closer to Rockville General Hospital than to Enfield to begin with,
Yes,
and some were closer to Bay State to begin with than Enfield, but we were looking at this from the sense of what would be the remaining closest programs to them.
correct.
Yeah.
We may come back to that. I want to take a look at the numbers again in terms of like unique patients versus patient visits as that relates to those two numbers that were provided. But for now, I will move on to the next question. In response to issue 6A, which is actually the bottom of page 5. So where it says specifics regarding revenues or losses that JMH or Trinity have experienced in September 25 that are directly related to the cessation of the rehab services. So JMH indicated that its rehab services were operating at a break-even or moderate positive operating margin until May 2025. Does St. Francis operate those same services with the same margin?
I don't have that information actually. It would be a little bit different, being based as a internal hospital-based program with a different mixture of colleague exercise physiologists versus nurses. But I don't have the actual data to probably answer that question appropriately.
And the same would probably be applicable to St. Mary's as well?
That's correct. That's correct. Yeah.
Okay. Believe it or not, I think we're almost done. So looking at the bottom of page 6, issue number 4E, that's 6E. So I think we're having a little bit of a miscommunication around what we mean by cost of services. OHS wants to try to compare the costs across all three of Trinity's locations, both commercial and uninsured. So asked differently, if patient A needs cardiac rehab, how much will each session cost at JMH, St. Francis, St. Mary's? Same thing for pulmonary. Are you able to provide that level of granularity?
We can, we should be able to, yes. I don't have it today, but we can, yeah.
And in the event that raises any confidentiality or proprietary information, you can file that under seal and we can take a look at it that way.
Okay.
I don't think it will, but because you're just going to be providing averages.
Correct,
But
yeah, I don't think so. Can I just ask, just a clarifying point there? It's per
Sure.
session. So I think what we had grabbed is by cost per patient in each of those classifications. So total session cost.
Okay.
Are you saying just by session? An average
I think
cost?
so. I can
Okay.
speak with. We're going to take a short break in a minute, and we can talk about that and try to figure out what would be most useful to the analysts.
Okay.
And I actually think we should take that break now, because I'm just about done with my questions. So let's take a 10-minute break. We can come back at 11 o'clock. Just a reminder to the public that public comment sign up is still taking place. You can put your name in the Q&A function of Teams, and public comment will take place immediately following the technical portion of the hearing. The technical portion of the hearing is almost done, so if you do plan to make remarks, please submit your names now. And a reminder again that although we will stop the recording, it's possible that you will still be visible and or auditorily heard. So just make sure you turn off your mics and your cameras. So we will return at 11 o'clock, and Faye, you can stop the recording.